días a todos. Si empiezo a hablar en español, creo que me voy a ir muy rápido. Si me voy muy rápido, acabamos más temprano, pero no van a entender nada. Y ahora estoy personalmente preocupado de que si voy muy lento y si voy en inglés, no vamos a tomar más tiempo. Pero bueno, encontremos el punto intermedio. Podemos interactuar por esta vía. Sorry, now I'm flipping to English now. I'm also a believer of this very big motto of no health without mental health. And clarification, I'm not a cardiologist. This weird species of decisions that early on decided not to pursue clinical practice. I started my research into it. I did a PhD in epidemiology and master's in epidemiology in London, and I have received financial support from these institutions, and luckily so far no industry funding. For this session, I have prepared like 4 big blocks, which I'm happy to share with you on the slides later on. But first of all, why are we doing this? Why do we need to look at our opportunities and challenges in our countries to address our health problems? And one of those points we can be the link to mental health and comorbidities. Challenges that we face upon assuming those tasks, and we're going to give an example of a couple of innovations that we're currently working on. One of them is actually Latin dimension, which I'll touch very quickly. Why content matter? Those who know me will get bored with this slide. I use it always and always and always. And it's because we have, to me, it's not to say we don't have a dog. To me, it's to say we have an opportunity to call it a beautiful dog. We have an opportunity to say and to lead the way into giving shape, form, color, size, to whatever we want out of this dog. Because right now, what we have is poor, limited, weakened, is under-resourced. And this is a challenge. What we have to do has to happen in this reality. And this picture is from Brazil, actually, from Rio, so very common for you. The other one is from Lima. When you take a ride on the bus to see the big capital, this old colonial part of town, very beautiful, that's one side of the picture. But if you turn back, this is the reality of most of our people. And this is the reality of the world. We're rapidly changing, we're rapidly becoming urban, we're rapidly developing newer challenges in urban areas. Our cities are becoming mega cities. Lots of population, lots of rural poverty, and so on. And I like to use this slide as well because when our messages hit the table of those who are making big decisions, such as these WEF, World Economic Forum, in a way, it's a signal of hope that we are not necessarily acting in isolation. This is a global risk analysis, and I think there are 2 or 3 health conditions that top up their list. And it's in these challenging contexts that we can find opportunities. And here I bring this information from epidemiology because that's how we were able and amenable to start this interaction with our colleagues from mental health. This study is a 3,000 people study being conducted in Lima, an urban shanty town. Kind of a desert. This shanty town was created, not created, but people invaded these local spaces. They gained property rights, and they started building their own houses. So, but before, it was a desert. And these are the challenges in the rural and in cities. And this is up in the north of Ecuador, in the border with Ecuador, where the country is also entirely different. This is a little bit of the sign, but this is the important part. When we're going to use it. The circles are the conditions. The size of the circles are the burden. The arrows or bars are the amount of coexistence of those two conditions. If I were to be Minister of Health in Peru, say, well, Jaime, this is what you have to do. Well, what would you do in Lima? What would you do in urban Puno, in rural Puno, which is 4,000 meters above sea level, Lake Titicaca? What would you do in Tumbes in the border of Ecuador? And what would you do in urban Puno? And we have these challenges. And I think, to me, these challenges bring opportunities on how best to tackle, how best to allocate these resources that are scarce. Importantly, depression. Big size here, almost as big there, not so important. See, people are happier in the depression? Maybe. If you look at diabetes, small in rural areas, starts getting higher and higher in urban areas, much so higher in this area. What's going on? Hypertension is the should be flat. This is hypertension. 20%, 10%, kind of no difference between rural, urban, high altitude, but 26%. And we start also exploring the arrows between depression and the other conditions. It opens opportunities here. So we'll be looking into depression and asthma. So we'll be looking into depression and what's this? Alcoholism. Maybe. From the cardiology field, this is the most used slide. This is the worst. Wherever conference of those clinical cardiologists who are interested in health systems, into delivering healthcare, this is a Cuba, this is monster. This is England using electronic data. People with diagnosed hypertension, there's no problem of resources, there's no problem of services, there's no problem of training staff, there's no problem of getting the drugs, but at the end of year one, only 50% of people are taking the medication. What's going on? And if you talk to a cardiologist, you, the patient, are not doing the job. But the other side is the people is not necessarily happier with that approach, maybe. And why don't we untap and unravel what's going on behind? And we did an important study. One master student came, visited, interviewed some patients, see what's going on. And a simple tool, say, do you believe in these medications? And hear the results. Certainly, as expected, the beliefs of harm and concerns about what we are prescribing are enormously high. And all of our practices, you take this. And we ask, do you take these? Do you have issues with harms and concerns? Maybe that opens a new avenue for conversation. The higher the people have this, the higher the scores in harm, the higher, 50% less chances of being on medication. The higher the score on your concern, I'm not taking this because it's right for me. 41% of less likely of being on medication. And this is another important necessity. Do I really need to take this medication? I went for my prescription, I went to the doctor, he gave me this. Close the door, the messaging came in. So these ideas of necessity are weighted to concerns, more likely to be adherent. So if I feel that I need this drug, that cannot avoid the concern of, this is, if I leave the room thinking that I need this necessity, I need this drug, I'm more likely to be adherent. I don't have to give you the paper. And this is fresh news, because we were meeting earlier in the week. Ricardo was showing you GVD 2010, this is GVD 2013. What's new? 2 or 3 days ago, the Lancet has come up with this and making a big fuss on this. Traditionally, global burden of disease analysis have said what people is dying for, therefore, if you die earlier, your loss of productivity, your potential loss is huge, therefore that single condition accounts for major burden worldwide. Okay, so an initial kind of a straightforward equation. If you die earlier, the more that you lose, therefore the more burden. Right now, they're looking into the sequela and the comorbidities as well. And this is the supporting key message of that publication. This roll up on the top is developed countries, rich countries. Middle is developing countries with South Africa. And this is demographic class number 1, the differences in the pyramids, not news to you. A large child base here in Africa, and people are getting older and older. People in developed society are much more older, whereas people in our countries are transitioning towards older age groups. What's important that is starting to appear are these more kind of, this move from this dark red into bluish, concentrated here, which is how many people are starting to live and to carry with that disability, therefore the higher burden. And this is the challenge that we are left out with. Based on those findings, we'll be transitioning towards health systems for multimorbidity. We should be ahead of time. The results of DVD 2013 show that people are living longer, people are getting treated earlier, with much more efficient mechanisms for treating, but with more diseases, and we can create disability. And I look forward to the day, 20 years, 30 years, 100 years down the line, when we see individuals coming to see healthcare, they don't see a specialist or a specialist in organs, not people. We need to challenge that early on. And this is about the link. Ricardo has started introducing this link towards integration, comorbidities, and now Paulo will also address a little bit of this before. Worldwide, mental health, I don't need to repeat, we will all tell you mental health is important. Depression is important, it's the most prevalent condition in the LMICs. Out of 75% of people who have this condition, only 25% have access to treatment. And there's an 11% lifetime prevalence of depression. And why? What are the pathways? Why do we care about this? So if you're thinking about your, so we should look into specific disease, a label of a condition, or how do these different conditions relate to each other? Taking the example of depression and diabetes, hypertension, I don't know what happens first. I don't know. But what is obvious is that depression can affect the progression of the other, can affect the disease management of the other, and can affect the mortality rate of the other, and likewise the other group. Here are some numbers. Comorbidity, this is prevalence. Diabetes and hypertension increase up to 3 times the risk of depression. There's no reference for that. This is management. People with depression have poorer adherence. Progression. Depression, having depression increases the risk for complications. So if I'm a cardiologist, if I'm a diabetologist, if I'm an endocrinologist, I should be looking to protect that side, mental health, so that benefits and complications of the chronic diseases are better taken care of. Stroke, heart failure, mortality as well, 2.3 times higher mortality. So we have to be very, very idiots not to buy the story of comorbidity. It's beneficial for both sides. And here the man is Ricardo and Paulo. Those two are leaders in our region in global mental health, so they are behind all these big reports and policies. But they're also very, very, very realistic about challenges, and I'm glad that Ricardo has done the job for me. He already have many of the challenges. Inequalities, stigma, access, policies, and so on. But this is important, this is where that we have to work with. We have to work with our fragmented healthcare system. No referral networks, insufficient human resources, and poorly distributed ones. If we're going to wait for the year when we have a Ferrari-like health system, it will never happen. it will never happen. So we have to start improving what we have. We need to engage. This is bunch of always given. We need to engage with the health system. Right? Testing, to test, to develop, to do pragmatic things within the health system. If it failed, it failed because we have a fragmented, weak, and the resources system. But if it works, it's a huge opportunity. But we have to be prepared to fail and to fail a lot. Integration. I know this is the talk of Paulo, so I'm going to skip this. And build collaboration. I'm very pleased to have a Peruvian fellow. He's not Peruvian, but he's Peruvian. We're on here from civil society. Thank you for coming all the way to join this capacity building effort. Because we need to span out by the moment that we produce the research, we write a proposal, we apply for funding, we develop the intervention, we test intervention, the funding finished, you move on to other projects, you write a paper but you're late, you interact with the editors. We're talking about 10-year time lag, and we need to fast track that knowledge transfer. We need to fast track that interaction also to develop the things that we would like to see tested, to see being tested. And that takes time. We need to build and nurture those relationships. Now I'm going to move on to the examples of the two particular interventions that we are working, improving collaboration with various groups. And we have used these to inform where is it that we're putting our eggs, where is it that we're placing our bullets. And this little plug has become very, very informative. Why? Because our magic bullet is not a drug, it's not a molecule. And we need to see, and we need to be very humble, but also aware of where is it that we're placing our targets. This tool has been developed to inform complex interventions. At the end of the day, we're giving complex intervention. See, whether you use a nurse, or a physician, or a promoter. Someone trained with 10 sessions versus 2 sessions. Whether the session was given person one-to-one, was it given online. Whether you use that in 2 hours or 4 hours. That idea that we are very, very strict and rigorous in designing randomized clinical trials. You have full workshop in the afternoon. Beautiful design, randomized clinical trials. We have the methods. But still, we're learning on how to test the different components because it's a complex intervention. And we have to see where is it that our goals are formed. So we have the sources of behavior, the functions, and the policy categories. And because this was introduced to us by our friend David from Australia. And at the very individual level, we have either motivation, we have capability, like me. Jaime, would you like to cook? I don't cook. Don't give an intervention about cooking. I do not like that. Maybe you can start here. Jaime, would you be interested in being motivated to cook? Okay? If you offer me a beer later on, maybe. Maybe this is the entry point to me. But right now, I'm entirely incapable of cooking. And not because I'm a Latin natural, because I suffer. Or whether it's the opportunity. Jaime, if you cook today, tomorrow you can play football. I cook today. I want to get out and kick something. I kick the ball. So how do we best play our best in triggering actions in the individual? But then those actions have to be deployed into center environments. Enabling, can I play football? No, you're lying to me because there's no football pitch. Why are you motivating me to cook if the carrot is to play football the day after tomorrow, but there's no football pitch? That intervention will fail. Coercion, okay. Jaime, you better cook or you're on a sleep watch. Okay. Okay, I have to cook. This comes from the theory of generating laws and traffic regulations and traffic, I mean, for cars. And also for penalties, carcels, prison as well. How do we understand and frame those interventions? Do we need education? Do we need persuasion? Do we need incentivization? Do we need coercion, training, enablement, modeling, etc.? So it's so complex. So when you plan your intervention, you have to see and be very aware where is it that you are activating and triggering, and where is it that you're not, and whether those activations are likely to reflect or to ingrain in the current societal architecture. And then the bigger one is the broader, the policy level type of thing. So we put more service provision, regulation, fiscal measure, guidelines, and so on. Go and look at the paper, it's very, very useful. So this is sample number 1. We're working with Pancho, the project coordinator leader here, Ayayanchu. Ayayanchu in Quechua means hello, is the local Andean language. Please notice very dry hello is hello, but it has the tacit innate connotation of how you're doing. And we're trying to primary healthcare providers to say, to have that in their usual practice. Why? I'm not going to complain about our Peruvian healthcare system. All the difficulties, all the faults, all the deficiencies, you name it, we have it. You name them, we have it. But, there are certain things that are working. As weakened, as fragmented, as under-resourced, as under-staffed, people are still coming to the health system, right? And where the most people, what are the profile of those who are commonly coming into the health? We have antenatal care. Antenatal care rates of service provision are way over 95%. We have pregnant women who are visiting, who are coming to stay. And what happens? 1 in 2 people with pregnancy or after pregnancy develop depression. We're losing that opportunity. Because we send them to that door, okay, only antenatal care, only your belly and your baby. We're not asking them, how are you doing? HIV and TB, treatment rate. Now it's easy to get access. Yeah, people are coming to receive their medications. They're coming to us, to this very awful, poor, weak, and fragmented, but people are still coming to that. And we know that 1 in 2 people with HIV, 1 in 2 people with TB, what they have? They have depression. Why are we not asking, how are you doing? Likewise with diabetes and hypertension. So, this is still we want to break training primary healthcare providers of those services, antenatal care, HIV, TB, diabetes, and hypertension. We give them a medical package to say, and you introduce this critical. 2 questions. I'm not asking you to do too much, but if I'm able to keep congruent with them asking, how are you doing? In the usual clinical practice, imagine the opportunity that we have. People are coming. People are coming to our weakened, fragmented, under-resourced, under-staffed health system, and we are not looking at it. Let's look at it. And what we want to motivate is whether or not, after those questions, we can insert these people who need specialized care into the route of seeking service. So, if you come to my practice and I'm your doctor, say, okay, would you mind if I ask you a few questions? And if you're eligible to seek the further level, my job should be to challenge you, not to let you go off, not to let you get worsened, not to let you develop a full kind of book type of depression. But here we come with the technology. You know that you can look for help. Do you know that in this service there's a psychologist that comes twice a week? Do you know that if you go 2 miles away, there is a psychiatrist who is willing to look at for you? Let's try to put people in this change of the system. And this has been the most important part, engagement. We're investing and investing and investing. Because the usual question, as in everyday business, is what's in it for me? Why should I be doing more today? We've been going through this formative phase. Pancho can tell you all about it. Pancho raised his hand. He's the man. I'm just presenting 2 slides, but we have those. We got the install package, training and implementation. Now we want to hear from patients where they're placing the right routes to look for service. Did they end up getting access of a specialized service? And we want to hear from the providers. Are you likely to integrate this in your practice? And we decided, and I wish and I hope that we can just actively trigger 1 or 2 or 3 of those the examples that Ricardo gave, community people lifting out their practices or lifting out their depression so they became active engaged. And then when people start using this, I wish it become viral. I mean, why do we all have cell phones today? Why certain practices are much more easier to be adopted? Then we turn into the next question and so on. Or at least we have to prove that it can be done, and when people start using it, it can be replicated. This is the other part of me. So we did our homework. We say, where are we placing our X? In terms of the individual, we're motivating patients. We're not coercing. We're not addressing the issue of capability, but we're here on motivation. In terms of the system, the red circle, we are looking, we're encouraging to look for specialized healthcare. Okay? Trying to put them into the roots of the existing services. And we're training providers and mental health. And in terms of the broader, larger round, we're increasing competencies. So we know that it can be a humble, limited approach, but we know, or we're trying to map where exactly is it that we are trying to pull the button, or push the button. This is the other one that brought us this week to think ahead. How is it that in 2 diverse countries such as Brazil and Peru, we can start doing things that 3, 4, 10, 20 years down the line will become normal? And it's the team that is in front of you. We're developing, implementing, and test CONEMO, this intervention, to help lower depression symptoms in patients with hypertension and diabetes. And I remember, in my own experience, we were having dinner with Paulo here in Sao Paulo. And I remember asking him, what's in it for me? Yeah, remember that? He took me to this, he doesn't remember what time we started. He took me to a Lebanese restaurant. He places this big pot of raw meat and told me this is delicious. I said, is this guy trying to kill me? I do raw fish, ceviche from Peru, but raw meat. We're having this conversation. I said, Paulo, how do you see, how do you envisage that your work is kind of, where is it confluence? Where is it? Say, what is information? And with that, I remember every project and every publication has a moment. To me, it's having raw meat with Paulo and saying, what's in it for me? And say, come on, let's do it. Would you be willing to give in and to try testing an intervention in people with hypertension and diabetes? He said, okay, I'm willing to give in. And I'm crazy enough to say, all right, let's try to put all the effort into developing something into mental health. I'm not mental health specialist. But let's try it. Let's try it. And here we are, 2 years on the line, ready to pull this randomized clinical trial. This is the application, and there is a lot of people in this room who know this better than I do. I want to invite them to raise their hands, please, for you to know this. Simone has been project coordinator, Julieta, Mark, Maria, who else is here? Lena, and Bunch. I wanted, anybody else? So I wanted to use these 2 or 20 seconds to invite you to join me in a round of applause to all of them for the great work that they are doing. Please, applause to them. This is our case. We decided to put together our joint fields. Now we have to do it. The Chandler's not in the room. She's putting the money. Okay. So, cool. People with diabetes and hypertension are screened for depression. We're breaking one step there. Let's do it. Let's bring these services closer to the people who need it. We know we have sufficient, strong evidence that this is a problem. Let's not wait to have, for the person with diabetes, for the person with hypertension, to write a note to say, dear doctor psychiatrist, would you mind seeing my patient? Let's do it right now, right here. So patients with moderate and severe depression scores or symptoms are given a smartphone with the app. And And there's an app team, that's Mark and Miriam from Northwestern University. They are not physicians, just app developers.
It's engineers.
Engineers.
Technologists. Well, no.
Technology. How do you describe yourself, Mark?
I would say I'm a technologist. I'm not a marketing transfer, so.
Depends on the day.
Okay. Thursday 11, June 11.
I would say I'm a project manager here.
So really, you need to integrate also in our research team these people with a diversity of background to see what is it like, or what is it the things that are going to work out there in the real setting. We need to move away from our standard physician-driven or healthcare-driven type of intervention. And then patient will use the app 3 times a week for 6 weeks. There's a nurse component as well. The nurse will monitor the patient use of the app, and there's a platform, there's a screen on the web that you can see, and you can track down individual by individual to see how they do and get text support. So the main outcome, we want to see if people transit through this line of technology, integration of services, can they improve the health systems? Another secondary question is, if that improvement in mental health symptoms, especially depression, do also translate into better adherence for diabetes and hypertension management? We saw earlier, this is my last 2 seconds, last to find out. Can they improve not only in their mental health symptoms, in their depression symptoms, but maybe you can also see an effect in their adherence for the chronic conditions. And we did our homework as well. Where is it? Where are the X placed with this intervention? It's a complex intervention. Individually, application for behavioral activation to promote behavior change. Of the structure in the system is a psychoeducational intervention that includes education, training, and empowerment components. And in the wider round, it is about service provision. We want to see if we have better ways of providing services. But it's like an auto-evaluation. The more that you write it right, it's beautiful. It all makes sense. But then, what did I write? What did I do it? What is it that I'm doing? Am I going to enter into this health system through this door, through this door, through that door, through that door? Or I'm coming here through the window. We need to make that effort to see. And the challenges, I'm going to just do fragmented, overburdened. This is important. People are protecting their areas. Why am I going to give in? Why am I going to let go? Let go. Things that I have fight for years to achieve and to accomplish. And also the use of technology. We need to adapt and to learn the challenges with the usage of technology. Randomized clinical trial, beautiful design. This is the microphone that we tested. 2 years. But what if a better microphone comes into the market? No, but I need to protect methodologically my trial. Let's keep using it. By the time we finish the trial, this microphone is out of the market. So those are the conversations, the challenges, and the tensions that we are facing within our team, which is useful because that drives not only progress in knowledge generation, but also progress in methodological advancement. How do we accommodate and we better design rigorous study designs in very volatile environments with this technology? We no longer have vaccines, but we have opportunities. So how can we accommodate it? So, this is my last slide. I am heavily biased. So I started with this slide and I closed with this slide. So whatever I taught you comes from this lens. That forces us to think only. Ricardo was very honest and humble and upfront saying we on the mental health side have failed because we claim, but we have not made enough efforts to go to. Reality is that there is no money for all the open calls. I'm sitting on a WHO committee looking into innovative financing ways for the challenges of NCDs. People were expecting that with all these political declarations, political momentum, burden of disease, availability of money, there will be an opportunity for securing funds in the same way that HIV and TB managed. Well, the world has changed. There's less money available, people are less willing to give money, there is earthquakes in Nepal, disasters in Haiti, financial crisis in corruption, China, but also, and being honest with ourselves, a lot of middle-income countries have graduated into higher middle-income countries. So there's a lot of capacity in terms of technical capacity in country, in different sectors, that we should be looking at innovative way to work with them. So the message was, there's no new money coming, please. So we better accommodate, adjust, and innovate on how best to tackle the research. Shall we talk to the private sector? Maybe, maybe not. Shall we talk to engineers? Are they much more efficient in running the process? We need to not wait for the big money to come to test those things. Okay, that was my closing session. So thank you.